Hi, my name is Hunsika, and today I'll be presenting on the rising global burden of acute myeloid leukemia. But before we dive deeper into this topic, here's a little bit about me. I'm a rising junior at Northwood High School in Irvine, California, with a deep passion for biomedical research and global health advocacy. Early this year, I investigated the use of CRISPR-Cas9 to target HPV oncogenes in cervical cancer treatment and presented this research on my findings through impact internships. I have also conducted independent research on the correlation between built environments, crime, and youth mental health, and I was selected to present my findings via research poster presentation for the National Health Literacy Conference. Additionally, I was chosen to represent my generation for the National Student Voices Campaign for Health Literacy. Currently, I'm participating in a summer cancer research lab through university lab partners where we explore the mechanisms of how immune cells can be engineered to target and destroy cancer cells. Besides wet lab research, I'm also participating in MuirCore's summer computational biology program, where I'm learning data analysis using microRNA sequencing of cancer patients for RNA biomarker analysis, understanding how to use databases to process and synthesize genomic data, and learning how to use the Linux cluster for data analysis. Outside of science, I've played the flute for 5 years. I'm a part of my school's varsity track and JV tennis teams, as well as my school's speech and debate and French club. Considered one of the deadliest blood cancers, the 5-year survival rate for acute myeloid leukemia remains around only 30% for many adults and is even lower in developing countries. This rare and aggressive type of cancer of the blood and bone marrow is characterized by the rapid growth of abnormal white blood cells in your body, and also referred to as AML. Typically affecting those over 60, this cancer accounts for 1 out of 3 leukemias in adults from the US and continues to be a risk to all ages, with around 4 in 100,000 adults and 1,160 children being affected annually in the US. Primary causes of this disease include prior cancer treatment, old age, chemical or radiation exposure, family history, and tobacco use. Common symptoms include fatigue, fevers, headaches, unexplained weight loss, anemia, shortness of breath, wounds not properly healing, petechiae, and joint pain. Common diagnostics for identifying AML include a complete blood count, bone marrow biopsy, genetic tests such as immunohistochemistry, physical exams, and medical history. Current treatment methods primarily include the 7+3 chemotherapy regimen, allogeneic stem cell transplant, remission induction therapy, hematopoietic stem cell transplant, hemodynamic monitoring, consolidation therapy, and specific drugs or medicine targeting mutations. Besides the high number of cases in the US alone, acute myeloid leukemia poses major challenges in global health because it's a rapidly progressing cancer with increasing incidence, substantial mortality, and complex risk profiles. Globally, incident cases of AML nearly doubled from 79,000 in 1990 to 144,000 in 2021, and death cases rose from 74,000 to 130,000. With the disease burden rising rapidly, the health disparities become increasingly apparent. AML has a disproportionate effect on high-income countries due to aging populations. However, low- and middle-income countries often face higher mortality and poor outcomes because of limited access to diagnostics, advanced treatment, supportive care, and a gap in health literacy. Treating AML can be extremely expensive and resource-intensive, and in areas lacking robust health infrastructure, delayed diagnosis and limited access to therapies result in higher mortality and increased suffering. Additionally, excessive tobacco use, high BMI, and occupational exposures to harmful substances such as benzene are all dominant in developing nations. These variations reflect broader environmental and lifestyle health hazards, highlighting the lack of awareness surrounding health risks and the need for proper region-specific policies. Survivorship must not be dependent on geography, income, or health infrastructure, making AML a major global health challenge. Besides the addition of increased policies such as early screening, equal access, and other region-adaptive interventions, the most effective solution lies around advanced in genomics, targeted therapies, and new diagnostics being made accessible through global partnerships and equitable policy action. Which brings me to my research. Through focusing on identifying common genes across healthy and AML patients, my research revolved around answering the question, do differences in gene expression contribute to the development of AML? By analyzing what genes are cancer-inducing, this data leads to the advancements of more accessible and cheaper diagnostics and targeted therapies, supporting developing countries. My research began by sorting through research papers until I found one with adequate data. Using the dataset GSC 142698 from NCBI, I found microRNA and mRNA expression profiles taken from the blood tissue of 24 AML patients and 24 healthy patients. mRNA reflects how actively a gene is being expressed, whereas microRNA regulates gene expression. I compared the data of the two groups through a program known as GHU, which uses a laboratory technique of microarray analysis to measure gene expression. Sorting the data and removing any outliers, I was able to generate graphs with two groups, early-stage AML and the healthy group. The volcano plot revealed upregulation and downregulation of certain genes. The box and whisker plot showed how the results of the dataset were roughly consistent across both groups, and the UMAP identified specific genes that were upregulated in the AML patients. Besides these graphs, a table was also generated with the p-value, t-score, and log-FC value, which I then used to sort the top 250 genes provided for pathway analysis. Using another database known as StringDB, I developed a model of all those 250 genes and their connections to one another. To simplify the model, I created a modified version to identify the relations of my gene of focus, the FLT3 gene, which is one of the most commonly identified genes of mutations in AML patients. I then used another database known as KEGG pathways to create an AML pathway involving genetic mutations in the FLT3 gene, which disrupts normal blood cell development by promoting uncontrolled cell division, blocking the differentiation between blood cells, and impairing regulated cell death. Highlighting two specific pathways taken from that model, we can see that when FLT3 is mutated, it activates KRAS to drive proliferation, which then signals to AKT2 for survival and metabolism. AKT2 then activates CHUK, which then prevents cell death and supports the survival of cancer cells. Additionally, the PML-RARA fusion disrupts normal gene regulation, allowing increased expression of cyclin A1, which drives rapid cell growth. These pathways are just two examples out of the many genetic mutations that can be identified upon further analysis of different genes. Furthermore, based on the table showing the p-value, t-score, and log-FC values when I first analyzed my data using GO2R, I was able to identify which of the genes in the two pathways I just discussed were either upregulated or downregulated. In the table I've made, we can see that FLT3, CHUK, KRAS, AKT2, and CCNA1 were all upregulated. This brings me to my results. Certain microRNAs may control important genes like FLT3, IDH1, KRAS, and AKT2 that help cancer cells grow and avoid death. If these microRNAs are not working properly, it could lead to the development of leukemia through upregulation of genes in different pathways, as we saw through the KEGG pathway. Finding these microRNA gene pairs through analyzing these pathways enables us to discover new and improved ways to treat AML. Now, just like any other research, mine also has its limitations. The dataset only considered gene expression through a microarray of recently diagnosed AML patients, and it doesn't use advanced next-generation sequencing, which may yield different results than microarray analysis. It does not specify its data to geographic regions, therefore the results may vary across race and background. I have also taken a smaller sample size for my experiment, so this must be tested on a larger and more diverse population as well. Innovative precision medicine approaches in affluent nations contrast sharply with limited care elsewhere. This gap in AML outcomes highlights an ongoing global challenge that deserves our attention as the next generation of health leaders. My data on AML patient characteristics and treatment access provides actionable insights that can be used by health leaders to design targeted interventions where the AML burden is rising most quickly and inequities are the greatest. The three approaches I propose to address the AML burden include advocating for public health measures, emphasizing the need to share data, resources, and technology internationally to improve diagnosis and care, and encouraging research and policy solutions that bring targeted drugs, genetic testing, and optimized care pathways to underserved regions. Addressing how acute myeloid leukemia reflects these broader issues of disparities in access, the influence of socioeconomic status, environmental exposure risks, and healthcare delivery across different settings highlights the ongoing global health challenge of AML, which calls for us to find a solution as the health leaders of the future. Before I end, I would like to thank my parents, the Global Health Leaders Conference, the audience watching this video, and the MIRCOR program for guiding me through my research. Here's the list of sources that I used for my research, and here's my email to contact me. Feel free to reach out at any time, and thank you so much for watching.